You may have noticed that we did not do a diffusing for Joe's episode. PTSI is such a huge topic that instead of doing a short diffusing on such a large topic, we decided to give PTSI diffusing its own episode. In this and subsequent episodes, we will be doing our best to refer to post-traumatic stress disorder as PTSI. We think it's one small step we can take to help lessen the stigma and encourage people to get the help they need.
We are explicitly recording this podcast through the eyes of our own personal interest. We are not affiliated with any health authority or correctional body within Canada. The information presented on this podcast is not meant to be a substitute for medical advice. If you or someone you know is experiencing mental health related concerns, please contact a doctor or go to your nearest emergency department for individualized care. Some episodes may include explicit content and potential triggers. Listener discretion is advised.
Hey Kelsey.
Hey Becca, let's jump right in. I often hear things like, I've never seen a burning body. I've never seen people blown to bits. I wasn't the one who got punched. I wasn't the one to cut down the body. I've never been shot. I've never held my friend's hand while he died on the battlefield. You compare yourself to others, like I haven't seen things as bad as this other person. You compare yourself to others in that he's fine. Why am I not okay? Everyone's lives are so different. First responders experience traumas all the time. But the traumatic event or series of events are only a piece of the PTSI outcome. We all have different upbringings and childhood traumas. We all have different family relationships and intimate relationship experiences. We have different family structures. And of course, our mental health is all completely individual. I don't think it's possible to judge or invalidate any feelings, symptoms, or diagnoses, but it's so incredibly common. Stigmatizing words that those with PTSI can internalize, but shouldn't because they're 100% not true, are weak, dramatic, dangerous, attention-seeking, crazy, unhinged, unpredictable, incompetent, damaged. People say things like, oh, you're just stressed. It's not that bad. Get over it. You just need a vacation. You just got to push through. Go home and have a drink. You'll feel better in the morning. These words and phrases are so harmful, period. PTSD or PTSI is a big, complex issue that we can't possibly give all the information in one episode. What we will do is shed some light on PTSI, things to look for in yourself and your colleagues, criteria for PTSD diagnosis, the reason we keep saying PTSI instead of PTSD, and we will throw out some crazy statistics before we tell you about some PTSI comorbidities and end with some helpful interventions.
PTSI might not be clearly noticeable in everyone. In fact, Kels, I think we both know many people who meet the criteria for PTSI but have never thought about it themselves.
Yep.
What you might notice in a coworker, friend, or spouse, if they are suffering from PTSI or PTSI symptoms, withdrawing from people and places and not attending social events.
So people who previously would have attended social events are no longer attending.
Mm-hmm. Negative thoughts or jokes about death and trauma. I know we all have a lot of black humor to help us get through what we do on a daily basis, and black humor is kind of a coping mechanism for a lot of first responders, but it can be a symptom of PTSI, and the jokes that are about dying or not waking up or having nothing to live for, those are the jokes that like you kind of want to flag that can be a symptom of PTSI or another trauma disorder. Memory problems and inability to concentrate.
Not with like an immediate stressful event, but just over the long term, like just struggling with those. Easily
frustrated or irritated and angry outbursts, and again, having that be abnormal for a person, and self-destructive behavior.
Meaning?
Buying a really powerful motorcycle and riding it like a crazy person through traffic and weaving in and out of traffic, heavy drinking, drug use, things like that. Things that when they make the jokes about, oh, if I die and don't wake up, it's okay, ha ha ha, they're actually doing behaviors that could cause that. This isn't specific to PTSI, but we haven't talked about it yet, and I think it's important to educate our listeners who may or may not know the signs that a person has decided to die by suicide. There are a few telltale signs that you can watch out for. Now, if a person does one of these things, they're probably just doing that thing. But if they are doing more than one of these things, you have noticed signs and symptoms of declining mental health in the past, and it's really just out of character, you might need to worry. Some of these telltale signs are a sudden extreme change in temperament or personality. Some people become very introverted when they were all very extroverted before. They kind of collapse on themselves. They don't want to go out anymore. They don't want to talk to anybody. And then some people who may have been introverted or depressed before can become elated and extremely happy and extremely social. And that emotion can come from feeling the weight of making this decision to die by suicide lifted off of you, and you no longer have to carry that weight around, so they're like really happy.
Right.
Suddenly giving away prized possessions or family heirlooms or animals, or making extremely large and unusual purchases. If somebody's giving away their pets, or, oh, my mom who died gave me this bracelet and it means the world to me, I want you to have it, with no context.
Right.
Things like that. Extremely large and unusual purchases. I'm going to go out and spend $50,000 on a boat when I don't have $50,000. Things like that. A sudden extreme change in appearance, like having long flowy hair and suddenly cutting it all off and dyeing the stubble bright red. This one is a good example of if a person just does one thing.
Right.
They're probably not...
You probably just want red hair.
Yeah. I've done it a few times. But if it's in conjunction with other signs and symptoms, it is a sign that somebody may be thinking about dying by suicide. And giving up on personal hygiene and positive habits, just generally.
So I guess we can look at each of these individually as red flags.
Yeah, and then if you notice multiple of these things in conjunction with other symptoms or things that you've noticed, ask them. Like, it's so incredibly uncomfortable to ask somebody if they're thinking about suicide, but research has shown that you're not gonna put that idea in their head if they weren't already thinking about suicide.
Right.
Asking them if they're thinking about it. If they say yes, ask them if they have a plan. If they have a plan and they're contemplating suicide, they need emergency medical attention. They might be mad at you for calling 911 or driving them to the hospital or sending the police to their house, but you might save their life.
Right. And better to look like a overprotective friend or colleague than hear about something happening to them the next day.
Exactly.
Did you come across anything that you might notice, like, in a workplace?
It's kind of similar to giving up on personal hygiene and positive habits. Like, a lot of people will just give up on their work. Like, people who previously did a really good job just don't care anymore. Right. They might be combative, they might be aggressive with people, they could be overly enthused, right? Again, there's that double-sided of an extreme change in behavior. They could be like overly enthused, I'll take on that project, I'll do this, yeah, I'll do that, and they're doing everything, and that's not normal.
Right.
So, like, those are kind of things you can look for in a workplace. You may have also noticed that we say die by suicide and not committed suicide. This is because people commit crimes. They do not commit suicide. People die in the manner of suicide or die from depression, anxiety, or PTSI or other mental health diagnoses. This slight change in language is just another way that we can help lessen the stigma surrounding mental health.
I quickly want to talk about the criteria for PTSD diagnosis, taken from the medical database Up to Date and based on the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders 5th edition, so the DSM-5 as we know it. So there is 5 cardinal features of PTSD to include. So these are relevant for those age 6 years and older. Our first cardinal feature is exposure to the traumatic event, meaning exposure to an actual or threatened death, serious injury, or sexual violence via direct exposure, so it happens to you, witnessing it in person, hearing about it, or repeated or extreme exposure to an unfavorable detail of the trauma, excluding through social media, TV, online, and movies, unless it's related to work. So I imagine, police investigations when they're combing through somebody's computer and they find child pornography or I don't even want to imagine what else they would find that would be included in the exposure to a traumatic event. Our second cardinal feature is intrusion symptoms. So one or more of the following symptoms that begin after the trauma. Recurrent intrusive memories, recurrent nightmares or distressing dreams, flashbacks, intense or prolonged psychological distress related to exposure of a trigger, or significant physical reaction related to a trigger. And these are all associated with the trauma. Our third cardinal feature is avoidance symptoms. So you're avoiding reminders of the trauma, obviously beginning after the event. Avoiding internal reminders, memories, thoughts, feelings associated with the trauma. Avoiding external reminders that trigger some kind of psychological distress, such as avoiding certain people or conversations, avoiding specific activities or objects, avoiding certain places or situations. Our fourth cardinal feature is negative cognitions and moods. So this is the noticeable change in negative thoughts beginning after the trauma. So it includes two of the following: forgetting important pieces of the trauma, persistent and magnified negative thoughts about yourself, others, or the world, such as, quote, no one can be trusted, I am bad, the world is completely dangerous, my whole nervous system is permanently ruined. Ongoing negative mental state, fear, anger, guilt, and shame. Significantly decreased interest in or participation with important activities. Feeling detached from others. And the ongoing ability to harbor positive feelings of happiness, satisfaction, and love. And our last cardinal feature is arousal and reactivity changes. So these are alterations associated with the trauma. So you have two of the following: unprovoked irritability or anger outbursts. These can be either verbal or physical. Recklessness or self-destructive behaviors. Hypervigilance. Increased startle response. Concentration issues. And a sleep disturbance of some kind. So issues falling asleep, staying asleep, or restlessness. And finally, there are some criteria about the duration of certain symptoms, the actual impact of the symptoms we just talked about, and ruling out other potential diagnoses such as alcohol, drugs, or other mental health disorders before finally landing on that PTSD diagnosis.
So it sounds like a diagnosis for PTSD is pretty complex.
Quite intensive, yeah. But absolutely can be done and is done and is worth being done.
Yes, I agree. So as you heard, Kelsey was referring during the medical terminology, Kelsey was referring to PTSI as PTSD. That is because currently post-traumatic stress disorder is classified as a psychiatric disorder, but changing the name of PTSD to post-traumatic stress injury leads into changing the definition and understanding of PTSI from that of a psychiatric disorder to a biological trauma response that affects the nervous system. There have been concerns in recent years that the term disorder has such a strong stigma attached to it that it hinders people's ability to reach out for help. It's currently being argued, as of 2021, that this change of name and understanding will help lessen this stigma, encouraging people to reach out for help. While the debate is still ongoing and PTSI is not yet an accepted medical diagnosis, many professionals have begun using this term.
Personally, I'm really down for this name change. Do you know who's fighting for PTSI?
I don't. When I was doing my research, I just found people in favor of and people not in favor of. I didn't get a whole lot of specifics on who's on what side.
Fair enough. I expected to change the mindsets of those who have PTSI and those who know someone with PTSI, because it's such a tricky collection of symptoms to understand, really. Why is the name change still being debated?
So I found, in my research, I found that it said people who are resistant to the name change think that the name change wouldn't affect the stigma surrounding the diagnosis, and that without societal and occupational changes in regards to the acceptance of mental health and understanding, the stigma would not be lessened by this name change. I disagree, personally. I think it's a one small step we can take to start the change. But I think the culture of this ruggedness that is expected of first responders, and especially men, has had a huge impact on the number of people who come forward and seek help for their trauma. This societal expectation that men and first responders have no feelings, are always tough, always unwavering, is such a dangerous way of life, and it's causing first responders to die by suicide at alarming rates. Society is beginning to change this expectation. However, it's still very much ingrained in the customs of many professions, and in particular, the older generations of these professions. This is difficult to combat in workplaces too, because many of these experienced staff are in a position of authority over other staff, enabling them to perpetuate these outdated beliefs. But I think changing the name a little bit is a good start.
Mm-hmm.
My opinion.
I agree. I like it. And I've asked a few people I know with PTSD, and they're absolutely in favor. Because like I said previously, many of them say, I wish I hurt my knee. I wish I had a concussion. I wish there was something, an injury, specifically an injury, to show people that I'm not okay.
Mm-hmm.
And this is why I'm taking time off work. And this is the reason I am the way that I am.
Yeah, and I think when you look at the diagnostic criteria of PTSI, it's like so many, like, schizophrenia and bipolar and major depressive disorder. These are all disorders that people have. A lot of them have to do with genetics, and there's lots of and other factors as well for diagnosis. But PTSI in the diagnostic criteria is so trauma based that I really don't think it's a disorder. I think I really like a biological trauma response. Because that's what it is. It's a trauma response.
Mm-hmm. If the event or series of specific traumatic events never happened, you would never have this diagnosis and this collection of symptoms.
Yeah. And like just like a broken arm, if you hadn't fallen and broken that bone, you'd never have a broken arm. So I think injury is a way better term.
Mm-hmm. We'd love to hear what you guys have to think too.
Yeah.
Yeah.
Let us know.
Okay. Jumping to rates of PTSI. Bex, you are the statistic. This is a hard word for me. Bex, you're the statistic queen. I'll let you take it away, and I'll sit over here with my comments.
Okay. I don't love statistics that much. The smile on my face isn't that big right now.
You lie.
First responders experience PTSI at a rate 2 times higher than the general population. And current research shows that paramedics experience the highest rates of PTSI at an estimated 22%.
Wow.
It's a high number.
I don't know if this is true for everybody, but I've always thought that paramedics just fly under the radar of PTSI. I know they're included in this classic first responder definition. I just feel like law enforcement and military take the cake for our perceived typical PTSI patients. Paramedics, we see you, 22%.
Yeah.
Wow. That's probably like undiagnosed, like
it's an estimate. Yeah, right. It's an estimate. In my research, I found that one of the potential reasons that PTSI is so high in paramedics is because everybody thinks they kind of just fly under the radar, and they don't have these typical peer-to-peer programs and diffusings and debriefings and things that police officers and military do. Mm-hmm. And especially with just by nature of their jobs, because they're always out and about and they don't get those immediate interventions.
Right.
So that's some of the guesses as to why their PTSI rates could be so high. Mm-hmm. So PTSI has high comorbidity with a whole bunch of other disorders. So comorbidity means that there are multiple psychiatric disorders or multiple psychiatric injuries occurring at the same time. And so some things like depression and anxiety, it's really common for someone to have both. So that's what comorbidity means. It's what disorders are common when someone has PTSI. So some of these disorders are substance use disorder, which we've talked about a lot. People use substances to cope. Major depressive disorder, risk of suicidal behaviors, and acute stress disorder. Estimates from research in 2016 estimates that as many as 70,000 Canadian first responders have suffered from PTSI in their lifetime. And I feel like that estimate is low. Mm-hmm. It's also from 6 years ago.
If you imagine how many first responders there are out there. currently and past.
Yeah, and this estimate was from TEMA, and their definition of first responder is quite narrow.
Who's TEMA?
They're a mental health support group.
Okay.
Not necessarily just for first responders. I'm going to link their website on our website after this episode airs. So because their definition is quite narrow, I feel like the real number for us and our definition of first responders is a lot higher than 70,000.
A lot higher.
Yeah. TEMA stats also show that an estimated 40 first responders died by suicide between April of 2014 and May of 2015.
So was there like a specific something that happened during that time period, or is it just the stats from one complete year of that specific research?
I didn't find anything specific. I think it's just stats from one complete year of research. Okay. I found something really interesting when I was doing my research for this episode, though. Many of the academic articles and the research studies I came across consistently compared first responders' PTSI with that of soldiers in active combat.
Is that because there's a lack of research on PTSI and first responders, or there are actually that many similarities? Because I often hear first responders saying, well, I've never been in the military. I've never seen what they've seen.
Yeah, I don't know. I think it's the closest comparison.
Right.
I mean, what else can you compare consistently being exposed to death and trauma and violence and unpredictability to, other than active combat? I don't know. But Dr. Lynette Montero, a psychologist in Ottawa, stated that first responders have a greater risk of developing PTSI than soldiers in combat zones. Which is not to shit on anyone or any profession. We're just seeing horrible things in all of our respective jobs. Military suicides related to PTSI have also been extensively covered by the media, but suicides and PTSI in other first responders have been largely ignored by the media, but people are starting to take notice. Current rates of PTSI in the general Canadian population are estimated to be 9.2%. Canada actually has one of the higher rates of PTSI. With Australia being the highest. First responders average a PTSI rate double this, making the prevalence of PTSI among first responders almost 20%. With these estimates, 1 in 5 first responders will be diagnosed with a lifelong PTSI during their careers.
If you could see my face right now, 1 in 5. That's a lot of undiagnosed PTSI out there.
And that's 1 in 5 will be diagnosed.
Right.
So think of how many people are not being diagnosed.
Should be diagnosed.
That have PTSI symptoms or acute stress disorder or other trauma disorders.
I thought that was a lot in people that should be diagnosed. Not even people that
are diagnosed.
And how many people were missing?
It's a ton of people.
Oh my God.
It's a ton of people. It's way too many. All of these statistics specifically about PTSI and first responders have come from pretty small scale studies, however. There's been very few large scale studies, so it's really hard to get a super accurate number. But right now, that 20%, or almost 20%, is the
closest guess.
Yeah, is the closest and well-educated guess.
Right. Not just a shot in the dark.
Yeah.
But based on research.
Based on research from other countries and lots of other types of research.
I wonder why Canada has one of the highest rates of PTSI.
I don't know. I think it's Australia has it's 37%. It's massive. A couple more comorbidities that you guys might be familiar with. Compassion fatigue. That is another reaction to a traumatic experience. It mirrors some of the symptoms of PTSI, but not all of them. Compassion fatigue can lead not only to poor job performance, but also depression, substance use disorder, and flashbacks to traumatic incidents. So, compassion fatigue is like when something really awful happens on the job that a quote air quotes normal member of the public would see and be like, oh my God, that's horrible. As first responders, often we're just like, yeah, whatever.
It happens so frequently.
Yeah, it's just another day on the job. It doesn't phase. That's compassion fatigue. And also burnout syndrome. It's commonly experienced by first responders and is defined as a combination of overwhelming exhaustion, feelings of cynicism and detachment to the job, and a sense of ineffectiveness and lack of accomplishment. So this can result from work-related operational stressors over extended periods of time, and it's not the result of a single incident. So this is like, it's burnout, right? So it's your consistent overtime and your long shifts and your lack of morale, lack of support. Yeah, that's where burnout syndrome comes from. And
I think we all have experienced this to some degree.
I think so.
I say we. I'm not even a first responder right now.
You've been, though. You were a first responder for a long time.
I feel you guys. So there are actually a ton of co-occurring psychiatric and medical diagnoses as well. Bex, you touched on some of them already. So of those diagnosed with PTSI, 16% will have one coexisting condition, 17% will have two coexisting conditions, meaning PTSI and two other psychiatric conditions, and 50% of people diagnosed with PTSI will have three or more coexisting psychiatric conditions.
Wow.
So these can include depressive disorders, anxiety disorders, substance abuse, and personality disorders.
I did not realize the I just did all that research on comorbidity, and I did not realize it was that high.
I was shocked, actually. Medical comorbidities can be up to 3 times more common in those with PTSI, even after adjusting for the higher rates of smoking, psychiatric disorders, and substance use. So the major ones being higher rates of obesity, high cholesterol, tobacco use, hypertension, and diabetes. Some possible biologic markers of accelerated aging and dementia are also seen and being studied. And there are many other links in various studies. I won't even list them all. Just know that coexisting medical conditions are very common.
I've heard before that people with dark humor, it can be a sign, an early warning sign of dementia before. And I thought, really? Oh shit, all of us first responders are fucked. Like, oh no. Yeah. But that is really interesting. I don't actually think there's no actual causal link between dark humor and dementia. It probably comes from these psychiatric disorder comorbidities, but I've seen that before and been like, well,
I've never heard that.
We're all screwed. So mental illness in the working age population in Canada is estimated to cost $20.7 billion annually due to lost labor force and other costs associated with mental health interventions and mental health disorders.
Just in Canada.
Just in Canada.
20 million. Billion.
Billion. But currently there's no estimate for the societal and economic costs for PTSI specifically. PTSI, by definition, is repeated exposure to traumatic incidents, and first responders, by nature of their jobs, are constantly being exposed to potentially traumatic scenes, events, and incidents. First responder positions are characterized by both physical and psychological demands. These include everything from overtime, public scrutiny, work demands with outdated equipment, foot pursuits or hand-to-hand combat, lifting gurneys, risk of risk of death or severe injury, and witnessing or participating in traumatic events that may include death. There are studies that suggest PTSI interventions need to be tailored to first responders and the trauma that they're exposed to on a daily basis. I thought this was really cool because I've been saying for years that first responders should have like psychologists and counselors who are familiar with the job or have been first responders before, because otherwise you spend the first 3 sessions of with your therapist explaining what you do for a living. Right. And that's not necessarily tailored to first responders, but it's just something that I've always thought would be really helpful. So some of this research was really interesting to me. A quote from a research study that we'll link in the notes said, "There are many established psychological treatment guidelines for PTSD. But there are reasons to believe that first responders differ significantly from the general population and would benefit from a targeted approach to treatment planning. The authors present a cognitive behavioral model of first responder PTSD, which integrates important factors related to this population as well as an illustrative case study." I thought that they could just sum that up much better than I could. There hasn't been a whole lot of actual research into this, whether or not it would be beneficial for first responders to have tailored interventions for PTSI, but this study really kind of brought that idea to the forefront, and I think it's going to be really interesting to see where it goes in the future.
I think our last couple guests also had mentioned similar things, that when they were seeing a therapist or counselor who knew the job and who was familiar with it, was much easier for them to connect right away.
I think as a first responder, every time you tell people what you do for a living, which I know I do, I deliberately try to not tell people what I do for a living because I don't want to field the questions that come afterwards. Mm-hmm. Oh, have you seen this? Have you done that? Have you ever done this? Oh, what is it like? And it's exhausting.
The party question.
Yeah, it's the party question. Yeah. And you're the party trick. And I feel like when you're with a therapist or a counselor or a psychologist who doesn't know much about first responder professions, they have to ask clarifying questions so that they can better understand. And that's what they are, clarifying questions. They're not trying to make you into a party trick, but that's what it feels like, because you're so used to people like rapid firing you questions when you tell them what you do, and then now you're going to a counselor or therapist and they're doing the same thing. And even though it's from a clinical point of view, they're just clarifying questions, it feels like no different than just going to a party or going to dinner and telling someone what you do and answering all those questions. And it sucks.
And I also feel like if you can walk in there and they have seen other people that work in corrections, you feel like as a patient that you're not the unicorn in the situation.
Yeah, I agree. Yeah, I think it'll be really interesting to see where this research goes in the future. And there are a few first responder specific therapy programs out there, and we've linked a few of them on our website.
And we have some guests coming up that have been to a few different ones, so I think it'll be really interesting to hear about their experiences.
Yeah. So that's
like the counseling part. Another the earliest of interventions is the diffuse or the debrief. And I know, Bex, this is one of your passions. I think we need more time to discuss what a proper debrief would look like, but can you quickly tell us what a proper diffuse would look like?
So a diffusing is kind of your initial, usually they're done by peer-to-peer programs. They can be done with people who are certified in CISM, which is Critical Incident Stress Management. But typically in a lot of first responder professions, diffusings are held by peer-to-peer programs. So diffusings are that initial meeting with all the people that were involved. You get everybody together that was directly involved into an incident, and you kind of just go around and you talk about what everybody experienced and what was the hardest part for you, and if there's any big emotions or big thoughts that anybody's been having. And it's the goal is to bring the people involved in the incident kind of back to a pre-incident baseline in their mental and emotional state. So it's just kind of let all of those emotions and all of those feelings just naturally flow with the other people who are directly involved who might be feeling some of the same things. Some people I've heard it called like burping the baby before, where it like bubbles up all this stuff and bubbles up, and this diffusing is like you're burping the baby, and it just kind of letting all these emotions kind of flow out and all these thoughts flow out so that it doesn't overflow. And
I've just heard more of the like, you go into your diffuse and you're like, you're fine, I'm fine, I'm not going to say anything if I'm not fine because everybody else is saying that they're fine.
Yeah. And I think a lot of diffusings in a lot of first responder professions, while they have the best intentions, a lot of them are not done properly. And I think a big one for that is in the international standard for CISM is that management does not attend. And that is so that people can feel safe to say things that might be bothering them. Like maybe they think it's management's fault. Maybe there was a faulty piece of equipment. Maybe they're just mad and the morale's low. Or maybe they're just mad and they say things that they don't necessarily mean or want out there. But it just feels good in the moment to say it, right? So typically management doesn't come, and I feel like that helps people feel a little bit safer. And the culture is changing, right? So it's changing from everybody going, I'm fine, to someone up in the room will be like, you know what? I know you're not fine. You know, this is why we're here.
Right.
And then once one person starts to talk, everybody starts to talk.
Yeah.
Supporters of critical incident stress debriefing, or CISM, believe that 2 criteria have to be met for a diffusing to be effective. The first one is that the personnel leading the diffusing have been properly trained in all aspects of critical incident stress management. And I can guarantee you the ones led by management, they have no training.
I imagine that's
little training.
A feat as well.
Yeah, it's a lot of stuff. Like, there's a ton of stuff involved in critical incident stress management. And critical incident group debriefing is one of those things that's involved in that. And that's just one piece of CISM. The second criteria is that the providers are adhering to the internationally accepted standards of CISM practice, like not having management there, and like laying out the definitions of a diffusing and a debriefing very clearly. Mm-hmm. So we've talked about diffusings. A debriefing is something that happens quite a few days or weeks after an incident, and a debriefing is only supposed to happen with a psychologist, psychiatrist, counselor, somebody who is professionally trained to hold these debriefings. And by professionally trained, I mean they can actually provide, like, cognitive behavior therapy. They can provide other interventions that a peer-to-peer program or a CISM person is not able to provide. And the debriefing is held, typically a proper one is held off-site. It's not held at the workplace. It's only the people who are directly involved. Nobody else is invited. So there's a lot more to debriefings than that, but that's kind of the gist of what the difference is.
So like a diffuse is like a support, and a debrief is moving into the treatment.
Yeah, it's a much more formal process. And research has shown that early intervention within the first few hours of a traumatic event is crucial for the prevention or reduction of PTSI and PTSI symptoms. This makes research-based peer-to-peer programs, proper diffusings and debriefings, and other interventions incredibly important.
Mm-hmm. And once those debriefing and early interventions are done, we move on to actual therapies, long-term therapies of PTSI treatment. So PTSI is often quite severe and debilitating, and because it's a lifelong journey, intervention and treatment really is an ongoing process. A patient with newly diagnosed PTSI might be initially treated with medication or trauma-specific therapy, depending on the assessment by their healthcare provider, along with the presence of other comorbidities, as we talked about. Some of the trauma-focused therapies are exposure therapy, cognitive behavioral therapy, which we know as CBT, and eye movement desensitization and reprocessing, or EMDR. And I think we will talk about some of those later because they're involved.
Yeah.
Hopefully we can have a professional come chat with us about the actual treatment.
Yeah, I'd love to have a professional come talk to us about EMDR. Hint, hint.
Wink, wink.
Yeah. And we all know that I love CBT, cognitive behavioral therapy, so I think it's great.
This is all like treatment after we've had an injury or traumatic experience. How can we protect ourselves in getting it in the first place?
Yeah, like I feel like we've talked about this before in other episodes, and I feel like the protective factors for PTSI are really the same as the protective factors for a lot of trauma disorders and a lot of things that we come in contact with as first responders. So
they're protective factors for life, truly.
Yeah, I think so. I really think that's a great way to put
it. I just feel like I educate patients on these things all the time, whether they're medical conditions, wellness, like just being well overall, or specific psychological diagnoses. Like they're just
general good things to do life. So some of these things are a sense of community and belonging. So we've talked about this before. When you have a really good social network that you feel really comfortable with, and you feel like you belong, you have a sense of community. That's really important, especially to have people to talk about this kind of stuff with, especially if your workplace doesn't have either a very good peer-to-peer program or they don't have one at all. Having this sense of community with these people that you feel comfortable talking to can almost act as if like it's a peer-to-peer program. You can almost have everybody knows when you go to a party or have for drinks or whatever with your coworkers.
Leave your spouse at home.
Because all we do is talk about work. And it's almost like a very informal, untrained diffusing.
It totally is.
So that sense of community and belonging is super important. Another one is perception of the work group's ability to accomplish its major tasks. So essentially what that means, it's your morale at work. If your morale is really low and you have no confidence in any of your coworkers to get stuff done, it really hampers your mental health.
Mm-hmm.
And so having confidence in the people you work with is a really good protective factor against PTSI. And I know that's not necessarily something you can always control,
right.
But there are steps that you can take as a coworker, as a peer, to kind of help boost those morale things and help teach. Like, a lot of first responders professions have a lot of turnover and a lot of new people, and there's often the nurses eat their young, or the like, I'm not even going to get to know your name till I know you're going to be here for more than a couple years, and like stuff like that. But if we can make an effort to kind of teach these people and take them under our wing, we can increase morale, and also we can boost your work group's ability to accomplish these tasks, right? You can have confidence in the people that are around you. So there are little ways we can control that. Another one is the ability to exercise some semblance of control over your environment. And that kind of tag teams with the work group's ability and taking new people under your wing, right? Mm-hmm. Taking what little bits of control you can take and letting everything else go. Letting, you can't control who comes in and who comes out. You can't control decisions that or policies that are made from the government, come down from the government. Taking control over the little small things that you can, when you take your breaks, who you invite into your social circle, who you take under your wing, teaching new recruits, things like that. Those are all little things that you can control to help protect you from trauma disorders.
I think that works into the previous point well. You build that morale in connecting with these new employees, teaching them the right steps so that you can have confidence in them.
Yeah.
And yourselves as a team, I think hits all of these things.
Yeah. I think so too. Yeah, and it's really just boils down to putting effort into your peers and the people that you spend more time with than you probably spend with your own family, right?
Mm-hmm. And people see you doing it, and
it's infectious.
Totally.
Yeah. Some of the therapies we talked about can also be used as positive coping strategies, and they can also be used preemptively. They don't have to only be used after a diagnosis. So CBT, EMDR, exercise, diet, community, those therapies and those wellness strategies, they are also protective factors. Sleep, yeah. Compassion satisfaction as opposed to compassion fatigue. So taking steps to actively and mindfully practice caring about the people that you're dealing with. It's hard and it doesn't always feel good. But it actually can be, if it's practiced a lot and consistently, it can be a protective factor against PTSI, which is funny because it's kind of counterintuitive for us, I think. As first responders, we think, if we just ignore it, we don't have any compassion for these people, and we just pretend they're not even like people, then it won't bother me. But it's actually the opposite. Taking active steps to care about these people that we're dealing with, whether it be in a hospital situation or a police officer or a paramedic or correctional officer, taking steps to actively have empathy for the people that we're dealing with can actually be a protective factor against PTSI. And then again, things we've talked about in previous episodes, having a healthy social life, eating well, exercise, having a routine, a sense of community, meditation or prayer, talk therapy, and other things, mindfulness, all lessen your risk of PTSI.
And first responders need to look out for each other. Post-traumatic stress injury is arguably the most prevalent stress injury among all first responders. Interventions, treatments, and workplace programming for PTSI is still in its infancy in many professions. There are steps that first responders can take to protect themselves and their peers by exercising, eating well, practicing mindfulness, and genuinely checking in on one another. Together, we can help lessen the ruggedness culture and that stigma of stress injuries and increase the intervention options and availability. Any last thoughts?
I just think, we're all in this together. And you might not notice yourself that you're struggling, or someone else might not notice that they're struggling. But it's up to us to look out for each other and notice these things and speak up about these things. Because I know so many people who notice that someone is not right and notice that something's going on and nobody says anything. We all talk to each other about it, but no one actually talks to the person. It's awkward and it's uncomfortable, but say something. At worst, you're a little paranoid. At best, you might save someone's life.
Mm-hmm.
And so I just think we're, as first responders and people who've dealt with a lot of this stuff, I think we all just need to have each other's backs. Keep 6.
And I think if you are experiencing these symptoms, get help.
Yeah.
Your friends will thank you. Your colleagues will thank you. Your family will thank you.
I guarantee you that if you are thinking about needing help, the people in your life have noticed.
Yeah. And it's only just going to get worse.
Yeah. And I think people would be surprised once they come forward with how much the stigma has changed and lessened. I think people are so afraid to talk about it, and then they say something about it and people are like, yeah, like that happened to me too, or yeah, I felt that way too, yeah, like same, or I also take X, Y, and Z medication, or I also go to whatever therapy or see. Like, I think people would be genuinely surprised.
Mm-hmm. And we need more people to speak up because it's happening to so many people.
Yeah.
And everybody's feeling so alone. Thanks for talking.
Yeah. Thanks for listening to us, guys.
Yeah.
As always, if you or someone you know is struggling with their mental health, please seek professional help. For a list of resources, including crisis lines and counseling options, please visit our website at asyouwere.ca. Want to be on the podcast? Send us a message on Facebook, Instagram, or via email. If you want to support the pod, subscribe anywhere you get your podcasts, leave us a review on Apple Podcasts, like, follow, and share As You Were on Facebook and Instagram, or click the link in the show notes to donate. See you in a couple weeks.